and just say, Lakshmi and Michelle, thank you for this fabulous paper that gives some historical depth to this moment. You know, everyone talks about how this pandemic is unprecedented, and I think your piece really shows us a precedent, and you know how some of the dynamics that we're seeing in terms of racial and social inequity are predictable in many ways. But also, you know, just going back to 1918, it was a really complicated event. So I was wondering if you could maybe just start off, you know, by talking about the complexity of 1918. First of all, like, you know, it seems like the historical record is patchy, but all these different things were happening as it relates to, you know, racial injustice, medical inequity. We also have Antoine, who's just joining now, who shared a really great blog post with us a couple of weeks ago. So Antoine, I hope you can join in and participate as well. But yeah, the floor is yours. And if you could talk also, you know, both of you are involved in on the ground frontlines work. So you have lots of important stories to tell. So yeah, the floor is yours.
Thanks, Evan. And it's really, you know, it's really good to be here and to be able to be here along with Michelle and with Antoine, because, you know, sort of stepping back a little bit, I think our piece is also in very interesting conversation with his piece in the AAIHS blog, which of course is speaking about a very different historical moment, but we see these sorts of continuities, as you said. I mean, I think it might be, for me, it's helpful to think about the reason, I guess, that Michelle and I wanted to talk about 1918 influenza in relation to our current moment, which I think for both of us, if I may speak a little bit for Michelle, and then I'm sure she'll jump in, it started clinically because we were treating COVID patients, you know, sort of on the front lines in Baltimore. And of course, we're all aware of health inequity and health disparities as they relate to so many sorts of specific issues. But hearing repeatedly, as you said, Eben, people say, oh my gosh, this is unprecedented. And, you know, for me in my own work, I was very interested in 1918 influenza via the lens of disease detection, surveillance, and diagnosis, which is sort of my area of interest. So we started talking about 100 years ago, or essentially 100 years ago, and all of the kind of many overlaps, but also contextual differences between that moment and ours. And as you already pointed out, you know, we don't talk about cataclysmic events as historians of medicine, but of course there were cataclysmic events in that period, including World War I, including the Great Migration, including all of these sorts of issues of racial injustice. And then in the middle of all of this pandemic. So it seemed in some ways like a natural historical place for us to land. I'll stop there and let Michelle and Antoine kind of jump in.
Yeah, I'll jump in a little bit. And I'm coming at this not as a historian of medicine, but as a health equity researcher. And I think just to give some context for our audience of clinicians, I think a lot of us were unaware about at least the absent record in terms of Black men and women during this time. We were just talking about when Lakshmi first presented this work, comparing 1918 to COVID-19. She actually presented it at a case conference, and I was immediately struck by the fact that I don't remember learning very much about the Black American experience during this time, and how it seemed like an interesting and important story to be told. And again, it's interesting just to think back when we were writing this, that none of the racial disparity data had come in yet in relationship to COVID-19. And so we were just waiting for it. I think a lot of health disparities researchers were concerned, just given what we know about other disease processes and the disparities that exist kind of across the board. We were concerned. And so, you know, we started writing this paper before all of that became evident. And then it slowly trickled in during our writing process. And it just became more apparent that we really needed to tell this story so that we could hopefully really learn from the past. And I know one of the things that we went, I think, back and forth with, and I think one of the things I learned just about working together with a historian and getting feedback from other historians of medicine was that we wanted to be very careful not to say that this moment was exactly the same or that it could predict anything that would happen moving forward, but that if we studied it carefully, that there was potentially something that we could learn. And I think also just that throughout this, I think the history, there's just there's sparks of hope. I mean, this is a devastating time period, obviously, but what we really, I think obviously Lakshmi did so much work on this, on the historical analysis, but really conveyed that there was so much resilience and there was hope and there were, positive things happening for this group of the Black community during this time. And so we wanted to make sure to tell that story at the same time. And I think that was kind of our driving, motivation to make sure that we were telling kind of a full spectrum of what was going on.
Antoine, do you want to jump in with some initial thoughts?
I'm so sorry, I missed was there a opening question? Good morning, everybody, as well.
All good. We're just kind of getting to know each other a little bit. So first of all, thanks, Antoine, for flagging this essay as one for the group. And I would love to hear either further reflections on, since we last spoke, or, initial thoughts about this piece.
Right. So when I was working on my piece, I was looking for an article to reference on the 1918 influenza pandemic, and I couldn't find one necessarily. And after I sent in my final draft, I believe the very next morning, Lakshmi and Michelle's piece was published. And so I was kind of infuriated because I was trying to incorporate some analysis on the 1918 pandemic. But still, though, the piece stood out to me. So, I'm like, I'll use this for teaching. I'll use this for future research, writing. But I feel like it had perfect timing. And I'm happy that our pieces were in conversation with each other.
Yeah, one of the things that really jumps out to me from this piece is just like the scope of this earlier pandemic. 1 million deaths in the United States, 50 to 100 million people worldwide were killed. And here we are, maybe in the first wave, and this is talking about 3 waves that swept the world. So if there's any kind of parallel to the current situation, like we might just be beginning, this long time of trouble. Last week when we spoke with Tony Hatch, he insisted that counting Black bodies isn't enough and producing anti-racist, knowledge about science and medicine. And I think what you have here on the second page is, thinking about this event in a historical context, but also present and future opportunities. Everything from looking at persons of color in leadership positions, thinking about how folks are leading, persevering, and innovating, how restorative justice approach might tackle not just the specificity of the current pandemic, but broader structural inequalities that are producing these differential disease outcomes. But also, in the early stages of the pandemic, how it's all about leadership. And maybe a question for both of you, it's been a couple of months since this has come out, and I don't know how to put a fine point on it, but leadership in this country is complicated. I could use some French to describe the current leadership situation, but maybe from a nested clinical point of view, like what. So there's clearly a lack of unified leadership, right? But you're kind of here on the front lines, listening to a lot of different leaders. Not just Trump and Fauci, kind of on a national level, or the governors who are getting a lot of press. But can you point to other examples of more interesting, innovative leadership, more behind the scenes, that you're seeing in absence of this kind of power vacuum that we're seeing, or good leadership on a national or even state level?
Ha 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 ha. Sorry.
And maybe we should start using
It's like
French. I mean, it's
it's so
perfectly
tragic.
fine.
I can only laugh. I mean, so to again kind of, zip back out to the sort of like macro view, I do want to say, Evan, you mentioned this sort of table and this idea of like concrete present and future opportunities. And I have to say, that was Michelle's, sort of brainchild entirely. And I want to make sure that I give her full kind of due for that, because, and it also shows in a sort of meta way, I think, why historians and health equity researchers pairing together can be hopefully fruitful. So speaking of that table and this idea of what we can do in our current moment and how we operate almost from a grassroots level when there's a leadership void, I'll say that. Many of our kind of motivations for writing this paper were born out of sort of anger at mismanagement and a sort of lack of leadership. I think at first, one of the things we saw clinically on the ground was simply that we are dealing with a sort of mystery disease. And I say that as somebody who's interested in diagnosis and detection, right? So in March and April, we often, saw, and Michelle, please jump in here too, but we often saw an example of kind of clinical leaders attempting to catch up to the disease as we were learning about it. And then as we saw it as a kind of social phenomenon, as well as a biomedical and a clinical phenomenon. So there was, COVID, the physiological condition, and then there was COVID, the social condition. So there were, lots of examples of the way PPE was, PPE was both deployed and recommended. Hospital leadership, I think, was, as I said, trying to catch up to this kind of vanguard of knowledge. And then, of course, what we saw played out was very differential leadership. I mean, I live in Washington, D.C., and Muriel Bowser, I think, has really been a pretty phenomenal example of sort of local and city leadership working often against a kind of an unconscionably bad federal response. And we've also seen this, I would say, even along the political spectrum. It's not been just sort of red states versus blue states. We have seen, we've seen Republican governors and mayors who have actually responded quite well to this. So, as you said, there have been these kind of widening circles of leadership, and the very patchiness of it has also made it hard as a clinician, but as a patient, as, a family member, as someone whose loved ones have gotten sick. I think we are all experiencing this phenomenon on multiple levels. And so part of the impetus for this work and for the table was to attempt to address this, as academics and as clinicians.
Yeah, and I'll add to that. I mean, I think the two things I'll say, examples of leadership. I think I went to undergrad in Atlanta, Georgia, so of course I'm, I think I'm really proud of the way Keisha Lance Bottoms, who's the mayor of Atlanta, has spoken up about this issue and kind of what it looks like when you have to defy even the leadership within your own state and speak up against what is right and what you think is what's in the best interest of the people. So that's an example, but I agree with Lakshmi. It's difficult to do when you have one message going out, even in the city itself, and the state is kind of on a different page, and so that is challenging. And then I think the other point I will say is something that we brought up about the media, just in general. We talk about it a little bit in our paper, just the importance, I think, of the Black press and getting some of the message out. But one of the things that struck me, and I think sometimes we feel like we live in like an echo chamber because we're surrounded by clinicians and people who, I mean, at Hopkins, we're around epidemiologists, people who are really invested in this, and it's such a huge issue. And then when you walk into the community, it doesn't feel that way. When you as I do community-based participatory research, so I've been shifting some of my work to Zoom and phone calls, trying to get in touch with the community and figure out how people are doing during this. And it's still amazing to me, kind of the lag and like the difference between what we kind of know and understand in our ivory towers and what actually is going on, you know, on the ground. It was one of the reasons why I honestly wasn't super engaged with social media up until the last month or so. But I realized that, you know, the people in our communities, especially the younger generation, they really weren't understanding kind of the magnitude of what was going on. And I still think it's been a challenge to make sure that that message gets out there. But it makes a really big difference for them to have trusted leaders or people that they know are invested in their communities, giving back this information to them instead of just like hearing it, sometimes even from like our big institutions, right? Like that are coming and saying, hey, this is important. When sometimes even within those communities, you could use this example for Hopkins, the community relationship is complicated, I think, because of the history, right? With Hopkins and kind of like our community, for example. And so it really takes kind of these trusted liaisons. And I think the media is one way to do that. But it was something that I think I continue to be surprised by, just how, you know, it feels like such an emergency where we're sitting and people can have a really different experience of that, even in the communities. And so.
Yeah, and I'll say, linking that to our, you know, our historical sources, it was so fascinating to look at the, you know, the Black media, particularly in 1918, 1919, which is why we sort of balked at the idea that this is a forgotten or a lost pandemic, because it was not in the Black community, right? Like there was this reliance on trusted community-based periodicals, and of course there are these, you know, widely read Baltimore Afro-American, Philadelphia Inquirer, you know, so many other periodicals who are writing in this period, essentially trying to undo some of the dis and misinformation going around. So for us to read that in our moment was fascinating, and also heartening that some of these internal sorts of sources and solutions might really have kept folks protected. So that was very interesting as well.
So if anyone else has questions, just pop them in the chat. I can't see raised hands, or feel free to just unmute yourself. But sticking with the historical part of the article for a second, yeah, it's really interesting to go back and kind of do a history of all these different disciplines. You have, you know, these nascent formations of anthropology, evolutionary biology, genetics, and, you know, thinking about the historiography, not only through those emergent disciplinary formations, but, you know, Alfred Crosby coming in and saying that that segregation might have had like a cordon sanitaire effect, like separating these populations. But at the same time, I think, you know, it's important to keep in mind what you had in the beginning of the piece, just calling attention to the fact that those bodies might not have been counted. You know, now we've got a much more robust infrastructure for reporting death, but even now we don't have, you know, all the data aren't getting coded in particular kinds of ways. So there's a racial blindness. So yeah, I'd love to hear your thoughts on this this historiography. You have these white commentators at the time, you know, and this is when folks are trying to make sense of race. Before, you know, we know from Dorothy Roberts that race is a political construct rather than a biological entity. Like at the time, people are claiming that this is evidence of some kind of innate differences amongst populations. And I think you see, at least initially, there was a resurgence of that kind of meaning making in the pandemic, people trying to insist that, you know, here we have evidence of some kind of fundamental biological difference.
Yeah, speaking to the historiography, and then I'll stop. I won't, and then I'll let everyone else jump in too. But speaking to the historiography, I mean, I do want to shout out Vanessa Northington Gamble's incredible article from, gosh, I can't remember exactly, it's like more than a decade ago at this point, but really foundational for our historical analysis, because she's one of, you know, she's one of the first historians to, you know, essentially not get put off by the lack of data about Black folks during 1918 influenza, and really go, you know, she does an intellectual and a sort of social history looking at periodicals, which was a big source for us. And, you know, again, not being put off by the sort of lack of quantitative data. It's interesting, 1918 influenza, and I'm sure there are other folks in the room who can speak to this. It's tricky doing historiography of pandemics because there is the tendency to conflate them all. In so many ways, they, you know, like this idea of social analysis and revealing the most vulnerable and, you know, revealing who and what society values. That is a theme that is continuous across pandemics and epidemics. But then there are these contextual differences, right? Like, we can't compare 1918 influenza to the 19th century smallpox epidemic that had just gone before. There's an incredible historiography of yellow fever, you know, throughout the sort of Americas and the global South, just about 50 years before that. So there are these continuities, but 1918 is interesting just because of this dearth of data, and then looking at kind of other people who've written on this. Crosby, of course, has his, you know, as you said, Eben, his sort of famous line about it being a forgotten or a lost pandemic. Nancy Bristow in American Pandemic has a small section on race and the pandemic, but it's really not that much compared with others. And that was part of our impetus too for jumping in and trying to ask why and how and what implications that's had for historiography and health equity.
Got lots more questions, but I can let other people jump in too. One other thing that came up, you know, in 1918, you see, you know, they're not using the language of essential workers, but it seems like Black nurses are very much in a similar sort of subject position as, you know, the Instacart drivers and frontline, you know, underpaid healthcare workers and other folks who are in the current economy being treated as both kind of essential services for the more privileged, but also in a sense expendable. Part of what Tony Hatch was talking about last week is the ways that he saw as, you know, bodies were initially being counted, as a disparity was evident. You know, even if you look at the inconsistencies and incoherence of the Trump White House policy, you can kind of see it drawing back at the moment when these early reports of differential health outcomes are coming back. So Tony Hatch is kind of sourcing the pullback of the federal response as a response to the data in an interesting way. But I think, you know, this your piece is thinking in kind of a long historical genealogy about, you know, how we might understand the essential worker in the current moment. And to answer, Kevin, your question in the chat, yeah, feel free to type your question in the chat or just unmute yourself and ask away. But yeah, maybe before we get to Kevin's question, Lakshmi and Michelle, if you have any thoughts just about that category of essential worker and its historical antecedent.
Can I say one thing?
Sure.
Regarding that, that spoke to part of why I wrote the piece and some things I left out with clinical trials. And one of the issues with clinical trials, which is why I use HIV and AIDS, which is what my dissertation focuses on, was because in the 80s, epidemiologists were looking for participants in clinical trials. And I believe Uche Blackstock, she recently tweeted about this, is that they employed rather colorblind approaches, whereas they failed to consider, you know, poverty, people working service sector jobs, lack of transportation, things like that, where they couldn't participate in clinical trials. A lot of folks, they came back with responses that if they missed a day for work, they'd be fired. So they'd rather go to work than participate in a government study of a disease. And I think that we were seeing similar things with COVID right now. So I think that when it comes to the social aspects of diseases, and I would say that COVID, like a bunch of other diseases, are social diseases, as we see countries eradicating it without vaccines. So I think that those things need to be taken into consideration. Kevin, you want to share?
Yeah. Okay. Thanks. I'm never sure with Zoom whether I can just jump in. So what I found particularly interesting about your paper was that it debunked a myth for me about influenza. When I started, or from a European perspective, that is, I'm not sure whether, and that would be my question, whether the same applies to the US context. In Germany, when I started to look into the history of influenza and influenza as a disease and how we prepare for it and how we treat it, it was always said that it was a democratic disease and that it struck everybody in the same way. And usually what is then given as an example for that is that the Spanish king became ill and I think he even died from it. And so I found it kind of striking because every other disease is class specific or, regarding socioeconomic backgrounds. But with influenza, they said it wasn't like that. And now we see with COVID, it certainly is. So I was wondering whether in the US context, this influenza as democratic disease is as well something that is floating around in the discourse.
That's a great question and a great point, Kevin. I mean, I will say, speaking to COVID, which obviously we know is not a democratic disease. One of the other motivations for this paper was, we wrote it right after Governor Cuomo had said that COVID is a great equalizer. And he, he's caught a lot of flack, and there have been a lot of responses to that statement. Of course, he said it when his brother came down with COVID. And, from our standpoint, from a health equity standpoint, it was already evident, or we already had suspicions that was not going to be the case. In terms of 1918 and 1919, that's a really good question, actually, whether that sort of rhetoric was circulating. I don't know the answer to that. I would have to look into that a little bit more. I don't know. I'm gonna leave it at that. But it's certainly famous people had it. Certainly, we know that there was this sense that it was a kind of moving finger of fate that could strike anybody down at any given moment. But whether there were explicit statements that it was sort of an equal opportunity blight, I don't know. So let me think about that and get back to you.
Even so, I would add that if people were infected at similar rates across socioeconomic status, treatment isn't necessarily meted out equally. The whole theory, Evan, we talked about this last time, of necropolitics, deciding who gets to live and who gets to die, and we see that with the ventilators and everything. So, and bunch of poor working class folks being turned away, saying, "Oh, it's just a common cold," or if you have asthma, so it's nothing for you to worry about, and they go home and they die. And I have a mentor at University of Texas at Austin, and they're planning to reopen the school despite a Black janitor dying from COVID. And people at UT Austin are saying, "What is it going to take for a white person to die for us to take this thing seriously? Like, one of our own has just passed away from this disease, yet we're still planning to reopen." So I think that all of these factors need to be included in our analyses.
Yeah, and predisposition. Oh, sorry, was that Michelle?
Oh, go ahead.
I was just going to say, one other thing that's important about this historical moment that we talk about, and others have talked about at much greater detail, is the idea of sort of pulmonary predisposition as being really central to the Black American narrative in particular, or the white American narrative about Black Americans. So, speaking to this idea of race sciences and eugenics, and, if we think about the post-Civil War, sort of racially stratified pulmonary function testing, like Lundy Braun and other people have worked on this. So that was part of the influenza narrative as well, because as we do know, a lot of people were dying of superimposed bacterial pneumonia, which is again a distinction from our moment with COVID. So this rhetoric that Black Americans were already, sort of compromised or sort of predisposed to pulmonary disease kind of cut both ways. So I think in that regard, that's another sort of tenet to add to this whole discussion.
Can I just jump in real quick? One thing that became interesting in this discussion to me in comparing the past and present, which may be actually quite obvious, the fact that the role of technology, the idea of online virtual communication being enabled for knowledge workers who are in a socioeconomic status that indeed actually rely on the so-called essential workers who have to be physically present, but perhaps maybe paying attention to that is one way to also think about the myth, or to demystify the equalizer argument. But I actually was wondering if we can speak more to the role of Black press or Black media in as also playing a role in not only archiving or recording history, but also offering alternative voices and concerns. Could you speak more about that? Thanks.
I don't know if the question is really about the historical context, the way that we spoke about it in our piece, and Lakshmi, you can feel free to add to that. I mean, I think what I touched on earlier, that there's a legacy, obviously, of distrust, I think, within the Black community, and so I think people rely heavily on those consistent kind of voices that have shown up for them before, troubling times, to relay information. And we know that, from like a kind of a bigger level, this is kind of the work actually of Dr. Lisa Cooper, who's a senior author, who's done just a lot of work, I think, on racial concordance and trust, even, kind of at the patient provider level. But I think we see that it plays out, I think, in this sense too, in terms of the way that people trust, I think, certain media outlets to do what they think is best for the Black community. And so there's this sense that they don't have an ulterior motive. I think that's kind of like my broad sense from the community kind of perspective that I work in, like in present day. And I also think because of the age that we live in, like I said, what's happened too is I think social media opens that platform for, it's not just, that people are relying on kind of what we think of as traditional Black press too, but they're looking at people who have a platform, right? And so, I mean, to be quite frank, it's like the movie stars that are coming out and saying, hey, it's really important for you to do this, because they have a platform to say so, that people, like especially the other generations, are listening. And so when Idris Elba said, hey, I actually, got this infection, this is real, this isn't something like that's a myth, people probably listened to that more so, like they said, oh my gosh, this is a real person who's like me, who's getting this, it means that this could really happen. And so I think in that way, it's also a little bit different, I think, than historically what we think about as like the Black press. But at the same time, the organizations that were still present or that were present there that we talked about, like the National Medical Association, still has like quite a strong footprint. I think like they still have a presence and a voice in the African American community. They release position statements. They've had just such a long tenure, I guess, that it's something from a clinical side that people do respect and listen to them and expect that they're going to do what's right for, I think, the Black community. So you still have those organizations, of course, like the NAACP, other big organizations that we think of more traditionally, that end up being really important. But I'll let, I don't know, Lakshmi, if you have anything else to add in terms of kind of like the historical perspective. But
No, I mean, I think that's spot on. And I would also add, actually, through social media, people like Michelle and Lisa Cooper, like Black health professional sort of thought leaders who are posting things on social media. And, again, as a historian, I'm just fascinated, like, what is this archive going to look in 50 years? Going to look like in 50 years. I'm always fascinated by, how Twitter is going to sort of help us or not help us maintain those records. But these are people, Uche Blackstock, right, who has 50,000 followers and, tweets very, very legit stuff, and is widely read and trusted. So I think, that's like another kind of historical source that doesn't exist for us when we're thinking about 1918. I mean, looking at the 1918 records, it is interesting to see all of the sort of church announcements, school postings, things like that. One of the things that didn't make it into our article was a really fascinating little anecdote where actually it was a pastor, a Black pastor, was called out by, members of his community for continuing to hold services during influenza. So there was this kind of, intra-community discourse about who's taking this seriously, who's not. And it was, quite a tongue-in-cheek little announcement about how he was mid-service and was forced to sort of shut down services. At the same time, then there are also all these narratives about churches dispensing so much community health wisdom, which we see is very resonant. Michelle can speak much more to this in the current health equity and community, research context as well.
I'll just add one thing, if y'all don't mind, to the social media thing, and especially in this era, a lot of folks in my circle with short attention spans, like I literally send them tweets from physicians and scholars on COVID-19, rather than, because I was sending articles, but like I have family members who say that my piece is too long to read, and it's not that long at all. So like, social media has been very helpful, I think, in getting some people to take the pandemic seriously. At least I can say, like I said, in my circle, I'm not sure if anyone else has similar experiences or not. But that's one way that I've utilized it to spread some information on COVID.
yeah, I would absolutely agree. I mean, I kind of spoke about this earlier, but it's actually pretty remarkable how different people experience this, obviously for a lot of reasons, but in terms of understanding kind of the gravity of the situation, I posted a graphic that I put together for a talk about the racial disparities data on Instagram, and there were so many people who actually had no idea, and even as but partly because there's a lot of mixed messages that are going around, right? Like people are very confused about thinking this pandemic is over and that it was time to, resume life as usual. And I was like, we're over here on the other end. We're just like, I'm in Texas right now. So, you are seeing the numbers because you are in the medical community, but, the snippets actually work a lot better. Like the picture of the graph that shows this is disproportionately affecting your community. You see the bar graph go across, it becomes like so much easier for people to see that. And that's actually what gets reposted and shared and everything. And nobody in my family was reading even our article. Like it was too long. Like, I don't think anybody, I think like 2 people in my family read it from start to finish. And, the big piece was, I was like, well, there's a table, or, there's something that you can actually digest. And I think that actually becomes really, really important too, as far as making sure that people are aware. So I think I've always felt that it has to be both. from a health equity standpoint, we definitely have to do the work, and, you know, we have to do the academic piece. It's so important. But if the people who need to hear it the most can't get it in a meaningful way, then we've also failed and we haven't done our part. And so I think it does have to be both. And I think that that's where social media, especially like Twitter, which forces you to kind of be a little bit more succinct than, as you can see, like I think all of us like would explain things forever, right, if we were given the opportunity. So it is fascinating. It'll be interesting to look back on all of this. Yes.
So for me, one of the key findings that this article highlights from 1918, 1919 is this phrase that's for non-clinicians probably hard to parse, the higher case fatality rate that you're seeing in communities of color. And I think another key thing on that same page that you're doing is not just situating that that finding in terms of individual bodies or individual health cases, but you're situating it within the unequal provision of healthcare, housing inequality, malnutrition, chronic respiratory disease, increased epidemiological burden of infectious diseases. And maybe in part, this might be a question to the artists on the line. Like, is there a way of representing, and for you who are clinicians, like, can you unpack what you mean by higher case fatality rate? I think I understand what that means, but, you know, as you unpack it, the artists on the line, I wonder if there's a way to graphically represent that. Like, how do you represent that higher case fatality rate in relation to these structural inequalities in a way that's readily comprehensible? I mean, that seems to be one of the key findings of this article.
Yeah, and you know, we see it in other, I think we see it in other conditions too. Most of my research is actually on racial disparities in maternal health, and we see it there as well with something like preeclampsia or high blood pressure during pregnancy. And the way that I explain it, and it could be explained the same way, is that, you know, 10, you know, let's say 10 black, I usually say 10 black people and 10 white people walk into a room, and, you know, 5 of them each get exposed to the disease, and all 5 of the black people die and only 1 of the white people dies. And that's where you have a higher case fatality. So it's not necessarily all of the time that it matters who, that people get a disease. We care too how people respond and recover and or not recover. And so if even if there's a less local spread within a community, but more people are dying if they get it, it becomes more dangerous for that community. So, I mean, I hope, you know, that's how I usually like try to explain it. And it would be great, I think, to have that in a graphic too, but that's how I explain kind of some of the urgency that, and we, again, from a health disparity standpoint, we see it for a lot of conditions that even, you know, I could say it for a lot of things that disproportionately impact prostate cancer, triple negative breast cancer. There's a lot of things that when you look at the Black community's experience, I guess, of that condition, it looks different. So.
Yeah, and that was exactly what Michelle said. And that was, as you said, Evan, kind of a key intervention of our article. Like, look, why are we not focusing on this? We talk about 1918 influenza as being somewhat of an anomaly amongst other pandemics, in that it appears that, you know, there's less morbidity or mortality in minority communities, specifically in the Black community. But why are we ignoring essentially that if you contract it, you have a higher likelihood of dying from it, as Michelle said. And that's how I'll explain it to my patients. It's a stark way of explaining it, but it helps me to frame it as a sort of, let's talk about the social and preventive aspects of this, because unfortunately it's entangled, and we don't fully understand why you're more likely to die of this compared to, you know, your white counterpart.
I just had a quick question, and I've been thinking about, you know, the role of data collection, and really, you know, enjoyed looking over your table and how you're talking about, you know, the need for really transparent and clear, data collection. And I'm thinking about that in the light of this past week where the data from hospitals is now going directly to HHS and bypassing CDC. And so I'm just curious about your perspectives on the front lines, knowing kind of more about what that means. I mean, I think I know what it means, but from your perspectives, I was just curious about some of your thoughts about
that. I mean, I think that this is a challenging time. And unfortunately, I think it does go back to leadership. I think, you can't change what you don't measure. And so this idea that like, we could potentially not have access to the data. I think it's very disheartening. I think the idea that if we potentially stop measuring it, the problem will go away, which I think is I think that's what we are all worried that maybe some of our leadership thinks. I think that's the challenging part. I also think that I'm even more concerned because just the idea that we started finally capturing some of this race ethnicity data, but I still think that at other intersections, like important intersections of vulnerable populations, in the criminal justice system, prisoners, pregnant populations, though that data still hasn't really come out in a way that's been meaningful. So even though we're starting to get kind of like the baseline, we were still missing a chunk. And so the idea that we're even going to be pushed even kind of further away from that, I think is it's tough. I don't know what else to say about it. I think all of us feel like we're living in an alternate reality sometimes, but that's the way it is. I think from Hopkins' standpoint, they've reassured us at least that they are still going to be able to get the data. I think they have, obviously been a place that people are going to help get a sense of the numbers. And they said that it wouldn't necessarily affect them. I don't know the details of all of that, but I hope that we can continue to find ways to get this information, even as like certain paths are closed.
I think Melanie had her hand up, but maybe I can jump in after her.
Yeah, go for it, both of you.
Okay. Yeah, actually, I mean, it follows up on this question of, I guess, data production, recording, and ignorance. And I mean, I enjoyed reading your articles so much, and I learned so much because I find 1918 has been brought up quite often in discussions and media reports, but always very superficially, or often very superficially. So my question is about how it became a forgotten pandemic, because what you show so powerfully in your article is that there actually is an archive. So at the time, there were a lot of people writing about it, like various, like the media, the black media, you refer to the church records, the obituaries, etc., and you reconnect this archive in a very powerful way. So when did this well-recorded pandemic then become a forgotten pandemic, the 1981? But I mean, we're probably witnessing something similar happening. I mean, at the moment, I don't know, with all the political stakes, with all the political stakes in recording and documenting and archiving.
Yeah, I think fascinating question. In my other life, I also I'm a literary scholar, so I'm like a sort of literary historian. The reason I bring that up is because I'm often very interested in what are the sort of literary and cultural afterlives of pandemics, and I'm teaching a class on pandemics in the fall, and I cannot find anything for 1918 influenza. The reason, I think that's really, it's so interesting because, when I move into, for example, my HIV unit, there's plenty of both historical, literary, cultural, dramaturgic, all of these sorts of texts. 1918 influenza, it just appears to have sort of evanesced in a way. I mean, Nancy Bristow talks about this a little bit, that the reason she became interested in the pandemic was she learned that her grandfather or great-grandfather or great-grandparents had died, and that's what sort of, you know, prompted her to search the archives. So I think your point about it being aligned with our current moment is an important one, because some of this kind of political oversight or lack of leadership, certainly in the American context, we see that. There is the question of, did it get overshadowed by all of the other things happening, in its immediate aftermath? It's a very, very curious point. I'd love to hear if anyone else has thoughts on this, but certainly it as a macro history, it becomes forgotten. But then, as you said, in the kind of micro, and if you really go digging, it does exist in these sort of individual accounts, micro histories, family stories, oral accounts, that sort of thing. But yeah, it's a fascinating, like, historical conundrum.
Just as a teaching resource, we read a piece by Mel Chen about masks early in the pandemic, and Mel reviews a San Francisco-based artist who just inventoried all the masks that were used in the 1918 pandemic, which is this amazing archive of images. But yeah, that could be of interest as you're searching for material for that class.
Just going along with the discussion, I thought to share some parallel observation in the Chinese context with regard to social media and data reporting. So most recently on the WeChat, which is the Chinese Twitter, Facebook combined, there's this circulating discussion about, in America, perhaps the reporting will go a different way than it is in China, like trying to not report so that the idea of returning to work can become more legitimized. I haven't really gotten to check to fact check, but I just kind of wondered about that. And then, of course, going back to the question of archiving, as is well known, the information control on the Chinese social media web is quite complex, but also one would say a lot, at least on surface, a lot more strict. But then recently I've been asked to review a number of articles that talk about the role of local narratives emerging, and I'm really kind of thinking about how much of that would indeed become knowledge, because one thing might be different between, say, the print media that was prevalent in 1918 versus the electronic media landscape that we inhabit, with, well, at least on surface, the ephemerality of the latter versus the former. So I'm just kind of wondering about those differences as well. Maybe others can chime in.
Does anyone have, we're kind of at the witching hour. We've got maybe the chance for either a response to Fan's Soraya. I think you're muted, Soraya. Oh, I see you talking. I think you're still muted. You could maybe type it in the chat. Oh wait, I think I hear you now. Try now. I'm very curious about what Saraya's question is. Yeah, feel free to type it in the chat. Thank you both. Thank you, Lakshmi. Thank you, Michelle. And thank you, Antoine, for getting us started a few weeks ago and for drawing our attention to this lovely piece. I think it's a really important intervention in the conversation. I'm dying to hear more about your clinical work ongoing. So I'm hoping that you're going to be writing more essays in the near future to come about all this important stuff you're doing now. So thanks, and hope that you come back.
Thank you for having us.
Thank you so much for having us. It was great.
Thank
Take
you.
care, y'all.
Thank
Thanks,
you so
everyone.
much.
Take care.
Cheers.
Bye.
Bye.